As we are recording this meeting, please refrain from sharing any personal protected health information. We are managing questions and comments in the chat, so please feel free to use the chat feature if you do have questions or comments. Also, you can feel free to raise your hand, come off mute, and ask questions during the meeting. We will be posting this slide deck that we are sharing after the meeting on the HICPUF Transition Stakeholder Advisory Council webpage. If you're listening by phone, you may press *6 to unmute your line and *9 to raise your hand. If you do require closed captioning, you can click the CC icon at the bottom of your screen and access that service that way. And if you need accommodations regarding this meeting, you can email this email address for John Barry, although this also reminds me, TSAC team, that I think we need to update this contact information. If you do need accommodations, you can either reach out to this email address that you see or one of us directly. What we do here at HICPUF is we administer Health First Colorado, which is Colorado's Medicaid program, Child Health Plan Plus, and other health care programs for Coloradans who qualify. And our mission is to improve healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. I'm really excited, as I mentioned, about the agenda we have. I think it's a really nice, rich agenda full of a lot of good information and presenters. So here's what this afternoon will look like. We are going to start off with a presentation by Jennifer Hansen, who is the owner and consultant with Helping Hands Consulting. And then Sarah Geisler, who is a team member here at HICPUF, will provide some information about rapid reintegration. And then Sammy Taylor will provide a walkthrough of the individual in-reach process for us. And then I will provide an overview about our LTSS PE rules. And then we wanted to give an overview of some future meeting topics. And then, of course, there will be time at the end for open questions and discussion. Any questions or comments before I move forward? Okay, and hi there, Jennifer. I see that you came on camera, so really happy to have you. This is Jennifer Hansen. She is the owner and consultant at Helping Hands Consulting, and I will let you introduce yourself a little more as well as provide some information about your agency. And Jennifer, I think you're on mute, so we can't hear you.
Yes, thank you for that. Yeah, I'm Jennifer Hansen. I'm the owner of Helping Hands Consulting. And if you just want to go to that next slide, Amy, I'm, essentially, and I'll tell you more about Helping Hands Consulting in a second, but I actually used to work for the Department of Healthcare Policy and Financing, and I was a long-term care policy specialist there in the eligibility department for about 3 years. And then 15 years ago, I resigned at HICPUF to start Helping Hands Consulting. And so essentially, we just specialize with anything with Medicaid eligibility. And again, I'll talk more about that in a second. But one of my goals for today was just to kind of, present how we typically support our clients in getting out of changing from nursing facility to the community. And a few reasons. One, show you how we can support if one of your clients or their residents needs that additional support. But also to educate you on some tidbits that we have found helpful over the years. So even if you don't need our support, that maybe it helps someone on this call, support the resident actually transitioning out of the nursing facility. You can go to the next slide, Amy. So first and foremost, so when we find one of our clients that's on long-term care Medicaid already, the 300% category, they're eligible for long-term care Medicaid, they've been in a nursing facility, how do we make this a seamless transition just from a Medicaid perspective into the community? There are a few things. One, first and foremost, we find that communication and coordination with the facility is number one. So we always tell our families, like right when we think we have, maybe not an ironclad plan in place, but that we're really starting to get the train moving in terms of transitioning out to communicate that to the facility. Okay. And typically we communicate it with a few people because the turnover is just so high. So what we find is like our main points of contact there in this regard typically end up being the social worker. And we still get the business office involved too, because the business office does a lot with Medicaid. So we find, even though you wouldn't think the business office should be involved, sometimes getting them in the loop is helpful. So just first and foremost, trying to tell them our plan. I usually say we need to start that process, putting a bug in their ear at least 30 days in advance. Okay. And then obviously they will be the ones to make the referral over to the case management agency to switch that from nursing facility, the waiver over from nursing facility to HCBS. Okay. You find some people will do that right away. Others, it goes in their queue. The regulation indicates that the case management agency, once they receive the referral from the nursing facility, should have 5 business days to come out and actually do the assessment. We obviously, agencies are behind. Some agencies are more behind than others. I think it is going to be important for you to know about how far behind the agency in that county you're dealing with is. But typically, just assuming it's just a standard, they're not crazy behind, just a standard, case management agency, we will start communicating with the social worker about 3 weeks in advance from discharge in order to send that 100.2 referral to the case management agency to make that switch. Okay. Here is why, because it's very important in order for this switch to be seamless, which is what we're all hoping for. Ideally, the paperwork is done and any reassessment is done while they're in the facility. The cert will not generate without, and the new HCBS certification waiver will not generate until there's a discharge date. It will not generate while they're in the nursing facility. However, in order for the agency to have enough time to come meet with John Smith while he's in the facility, it is good to do that, to start that process while he's in there. Okay. So we like the social workers to do that again 2 or 3 weeks in advance. The reason why we usually make that call 3 weeks in advance is because a lot of times, again, they're doing 800 things over there. So it could take them a week to actually get to it, to get all the paperwork together and send that over to the case management agency. So we suggest that we call and then we'll follow up with them to make sure it actually got done. All right. And then once the discharge has happened, or if we know for sure when it's going to happen, we make a call to that case management agency and let them know. So we make 2 calls regarding discharge dates to the case management agency. One is going to be to let them know, hey, everything's looked good. Thanks for coming out and reassessing or whatever needs to happen here for this, to switch it to HCBS. We think John is going to leave the facility, next Friday, September 13th or whatever. Just giving you the heads up. And then we will make a second call on September 13th when John actually leaves, because they really can't do anything until then. I'm just kind of putting it on their radar. John, I called on September 13th again to that case manager and say, John left the facility. All right. So that should prompt them to actually generate the HCBS level of care certification, switching that waiver to HCBS. Next slide, Amy. So one of the other things through this that's important is that anytime there is a change in waivers or a change in certs, I call them certs because of their level of care certification. At our agency, we just call them certs. Anytime there's a cert change, it could prompt a redetermination. Like, it is hard for me to look any of you in the eye and tell you how this is going to go down for each case. It depends on a lot of factors. Whether where I'm going with that is where the county or an eligibility side is going to want to relook at any financial information. HICPUF did just send out some pretty strong, agency letter directions on, ex parte review. So if they just got redetermined by another program, you don't have to relook at it for a certain period of time. And they're really trying to streamline the redetermination process. So it's all going to depend. A lot of it's going to depend on when this last person's redetermination was. However, if they have not had a redetermination in some time, I find there's a decent chance when this level of care is changed, the county may want updated bank statements as well. Okay. So what we do at our agency is we start working with that individual, making the assumption that Medicaid is going to do at least a semi-partial redetermination on this case in order to update the certification. Again, it's hit or miss. You may say, well, I don't see that a lot. Well, next case you may see it. All right. So it does vary across county lines. And it varies on the redetermination dates of individuals. We at our agency like to make a good practice and trying to work with that case to see if there have been any changes to the case that Medicaid needs to know about, to spark a redetermination. And also just trying to get updated bank statements, to make sure maybe their income didn't accrue, they don't need to make sure they pay the facility that last payment. And there's not going to be any issues maintaining that financial eligibility when that level of care is changed in CBMS. Okay. So we usually get updated bank statements, updated life insurance verifications, things like that to do a snapshot of the resource, eligibility for sure. I think when you get that information, you can choose to do one of two things with it. You can go ahead and send it to the eligibility site managing the case, or you can wait and see if they ask for it. Like I said, we kind of handle it on a case by case basis, but we definitely usually have it in our possession, because what we don't ever want is a verification request going out to this. We've got the level of care cert changed. We're discharging home, trying to get services set up, and then a verification request gets sent out to the client, and we can't get the information. So the case is then terminated due to not providing verifications. That's what we're trying to prevent here, because the whole, Medicaid's got to stay intact for these services to get set up. And the way we do that is to ensure they still meet resource eligibility, and we have all the verifications needed, to make sure we can provide that to the eligibility side if asked. Once, and this next one's a little tricky. So, we ensure the waiver change is updated in CBMS. HCPUF has made a lot of changes over the last years. The last year, I find it worked. The interfaces work for some cases. They don't work for other cases. It's really hit or miss. But ultimately, any waiver change has got to be updated in CBMS by the Medicaid technician, by the eligibility site. So even, so the case management agency comes out, they hopefully redo everything while they're in the nursing facility. We update them when the discharge date, once they get that discharge date, they should be able to send an updated level of care with the waiver of whatever waiver you are looking for, HCBS, CBD, whatever, to get updated in CBMS. Many times, services do not get set up. Petties and PARs do not get to assisted livings until CBMS has been updated. Again, I have found sometimes it's automatically, sometimes it has to be done manually, but nonetheless, that's something that you're going to want to make sure that you're making some calls to probably multiple agencies to confirm that gets done. So that's how we as an agency, I know that's, a lot of calls, but that's how we as an agency kind of micromanage this process to ensure, the services get set up. Because once the CBMS is updated, once, if financial information has been relooked at, if necessary, the assessment's been done, all that, really it should be pretty easy for the case management agency to either set up those home care services, or like I said, send that petty and par to assisted livings. One of the issues we see with assisted livings is they know the ball drops in this process quite a bit. And that's why it sounds like we're micromanaging it, because we are. And they know if one thing drops, they're not going to get a petty and par. Even if the client remains eligible, in the system, like in a portal somewhere, if it doesn't get switched to HCBS, you know what I mean? And the date doesn't align with their admission date, which is why it's going to be important to get all that paperwork done and that assessment done prior to discharge. They're either not going to get a petty and par to get paid, or their petty and par is not going to line up with their admission date, and there's going to be a gap in coverage. So that's why you find in general, there's not a ton of assisted livings that take Medicaid day one. And if they do, now a lot of them have put some stipulations in place that they want the petty and par pretty much almost before admission, which is sometimes difficult to do too. So anyway, I know this is a lot. Amy, next. I guess let me stop here before I move on to just other general things. What questions do you have? Is there anything that you guys see or issues you see that you want to bring up to me to see if we can maybe figure out a way, a best practice around it or something our agency has done to, kind of get around that. And if you don't want to ask it here, you can always give us a call. My contact information will be at the end. All right, next slide. So essentially what we do at Helping Hands, so when I started Helping Hands 15 years ago, it was for the purpose of just specializing in eligibility. So essentially, since then we've become, we've done over 10,000 long-term care Medicaid applications. I would say we have become the established leader in consulting for long-term care Medicaid. You can go to the next slide. And like I said, we really specialize with anything with eligibility. So, we can sit down with an individual and just have one meeting with them where we kind of tell them where they are, where they need to be, or, sometimes a lot of our clients are already on Medicaid. They know they're, again, they know they may be about to transition out of a nursing facility to home care. They want to know what that's like. They're contemplating selling their home. They know maybe a $10,000 inheritance is coming in, and they just want to talk to somebody about some options and what that looks like and how to stay on Medicaid. We can just always have one educational meeting with them. We help. Our primary service is that we just help people just from wherever they are in their process through the eligibility determination. So the average client comes to us like, hey, my mom's at home and she just needs to go into a nursing facility, or hey, my mom's at home and we need to set up services here. I just need to get on long-term care Medicaid. We can help people, guide them through that final spin down, help them get all the documentation, get all the bank statements, pension verifications, and then navigate that process for them. So we would deliver the documents, make all follow-up phone calls, represent them at any meetings that come up regarding it, with the facility or whoever have you, until we get that approval we're looking for. Again, we do a lot of waiver changes. Anyone who needs a pool trust, we can help, coordinate that with CFPD, getting that set up. And then we also, in certain situations, can become someone's financial power of attorney or court-appointed conservator, if that is warranted to get Medicaid. Like, let's say maybe, this person can still sign legal documents, but they can't get to the bank. I mean, they're just physically not able to get to the bank to get all the bank statements Medicaid needs. So we can become someone's financial power of attorney to be able to go get those bank statements, call and get that pension verification, get that extra support. But also we can do that even if maybe they already have Medicaid and they just need that monthly support of, paying some bills and things like that. But same thing with a court-appointed conservator. If a petition is needed to become court-appointed conservator to help someone get Medicaid or help manage their finances for maybe a future Medicaid application or something like that, we can do that as well. And so that's all I have. So I don't know, Amy, I don't know if this is what you were looking for, or if you have any specific questions or comments that have come up in the past at other meetings that you want to bring up about this process.
No, I think you provided a lot of good information, and it's so great to know that your agency is working hard to fill in a lot of the gaps and barriers that a lot of people face with the transitions process and other kind of Medicaid enrollment processes.
Mm-hmm. One of the biggest issues we see with cases in general, though, to get out of a facility, and I guess it's just kind of food for thought, or I'm just curious what you have to say, is that the services typically won't get set up until that HCBS cert is updated. The case, all agencies have communicated, updated. And again, that can't happen until a discharge date from the facility. So what we find, this presumptive eligibility, I saw that on the thing that may help with some of this, but we just find a lot of times if people don't have, or they're really trying to get back home, if they don't have that support, those first, 30 to 60 days when services may not be set up are very tricky for individuals. And that's why we try to front load it all while they're in the facility, because the faster, all of it happens, the faster the services are going to get set up. I guess my other comment is, I mean, sometimes, a lot of times, those waiver change requests are done like at the last minute. So the individual leaves, and the waiver change is not done until after they get home. And we just find that delays the process substantially, because then the case management agent has to get in touch with John, and he's hard of hearing, and he doesn't know who this agency is. And I mean, you know what I mean? And then you're really doing a lot of that work that we like to do while they're in the facility, all while John needs services at home. So I do find this transition to be very complicated for people who don't have a lot of support at home, don't have that spouse living there, or maybe children or church members, that can help support. So that's where we see a gap in these transitions for sure. And I'm sure y'all do as well. But always, if you have any questions, you don't have to send us a case necessarily. If y'all just want to run something by us, have a situation, you're not sure if we have any suggestions on how to handle it or anything like that, don't hesitate to contact me. Here's my information. We want to be a resource for you guys to support these individuals, getting them out. Even if it's not a case that wants to hire us or really get us involved, we're happy to support you as well.
Our last call for any questions or comments. I think this group would have a lot to share or offer or ask regarding this. But again, as Jennifer said, if you'd prefer to do it kind of on a less public way, there's her contact information. But regardless, Jennifer, we really appreciate this information and you taking the time to introduce yourself and share with us some wisdom.
Great. All right. Well, thanks, Amy. I'm gonna hop off then. Okay.
All right. Sounds good. Thanks so
Thanks.
much.
Take care.
All right. So my screen is frozen a little bit. Hopefully y'all can see me and hear me. Jennifer is frozen in our midst forever. All right. Well, next on, I don't know if it's just me or anyway. Next on, can you guys see my screen, by the way, still? And it says rapid reintegration.
Yeah, I can see it, Amy.
Okay, perfect. Thanks. My screen was doing something goofy. So next on our agenda is Sarah Geisler to talk about rapid reintegration. Thanks, Sarah.
Thanks, Amy. I'm actually glad and excited about going after Jennifer, because this kind of leads into another program that is going to be launched in January that we're going to introduce and roll out, and it has to do with transition services also. So some of those things that Jennifer just mentioned, we're actually are going to also cross-reference with rapid reintegration. So first, I just want to go over the purpose of rapid reintegration. It's to support members that are transitioning into the community with a more expedited referral process. And members will be given the opportunity to make an educated choice about community living options and transition services while they are receiving a nursing facility level of care assessment. So as Jen mentioned, as you want to get that level of care done for when they're coming out of the nursing facility, this process is actually going to be starting when a member is looking into going into a nursing facility. This is not additional work for TCAs, but it actually could benefit with resulting additional referrals. So I'll kind of go into what that ends up looking like. You can go to the next slide, please, Amy. So rapid reintegration will be triggered when a case manager asks the individual if they're interested in learning about more community living options, and they currently reside in the community or are in the hospital. So this is member states during the level of care that they're interested in learning about additional services for when they are transitioning back to the community. And you can go to the next one. This is a little bit about what the process looks like. If an individual expresses they are interested in community living options at that level of care, then the case manager will initiate the plan and the CCM system with additional barrier questions. and their barrier questions is based on their responses on one of three things on how the case would go. The first one, if they do not have Medicaid, then the case manager would be sending an escalation ticket to the department if they're not approved, like I mentioned before, for Medicaid. So that would actually stop the process for rapid reintegration. The second way it could go would be if they are making a rapid referral to transition coordination agency. If they have, for example, I will show you in the barriers questions and how it would look, but there would be a rapid referral that a case manager, which we actually, I think, talked about in the transition meeting yesterday that Jay was mentioning, how a rapid referral would be sent to the transition coordination agency. And then third, a rapid reintegration plan assessment would be something that the case management agency would actually keep the case if they don't have a lot of barriers. So you can go on to the next one. It kind of talks about a little bit of the barrier questions that we would have. These are just some examples of additional barrier questions that would be seen in the CCM system when a case manager would be going through the rapid reintegration process. They would be asking, does the individual have Medicaid? Do they have HCBS? Are there any complex health needs, such as mental health issues? Do they have the appropriate housing? Do they have a need for in-home care services or need maybe home modifications? These are just a few of the questions, so not all the questions that would be seen by a case manager when they would start that rapid reintegration process. Then you can go to the next slide, Amy. After that, this is when it would be determined if it'd be a rapid reintegration plan or a rapid referral. Some key terms, like I mentioned, you'll see there's two ways it can go. One would be a rapid referral to the transition coordination agency. This is someone that might be staying in a nursing facility for over 30 days and needs additional support to reestablish themselves in the community. The case manager would then make that referral to the transition coordination agency within 2 business days of that level of care. There's also the rapid reintegration plan, and this is for somebody that might have HCBS and have Medicaid, but have little to no risk as defined by the barrier assessment. So those barrier questions as that was shown earlier. They would then create a plan on how to support them when they would be transitioning back to the community during that level of care, that 100.2 also. Then you can go to the next one. There we go. Here's some key points to rapid reintegration. It is conducted again by the case managers during the in the CCM during the nursing facility level of care. It will be triggered when the member states that they are interested in learning about community living options. This does not start if the member says no, they are not interested in community living options. It would only be when the member says that they are interested. And then it does end when the member lives in the community living setting of their choice, and also a post-reintegration satisfaction survey has been completed. And this is something that the case manager would be doing. Again, we'll be training case managers. It'll be about the timeline of November, December of this year, and then implementation does not start until January of 2026 is what we're aiming for. So after all the training, then it would not start until 2026. If you can go to the next one. So I just wanted to bring up a couple things. Again, this would not have any direct impact on what you guys are already currently doing. If anything, it actually might bring more referrals, as in the rapid referral, and case managers making referrals to the transition coordination agencies. But I would like to kind of just get your input on any thoughts or ideas on how you feel that it might affect on your agency. Also, any support that we can go ahead and provide prior to it being launched in January would be helpful, so I can just make sure that I can support you guys during this transition. But we wanted to make sure that you were aware of this new program that would be going out and starting in January. So if there's any questions, or if you want to go to the next slide. I think then it has my contact information. So you can always go ahead and email me directly. My supervisor is Chanel Pugh. And then you'll also see that there's a couple websites or the links that you can go ahead and get to about the diversion projects, rapid reintegration, also community living updates if you have any questions. But if you have any questions for me now, you can go ahead, I'll open it up.
The quiet group today.
It is a quiet group.
All right, I'm not seeing any hands raised or any questions in the chat. So thank you so much, Sarah, for this information. And I'm sure more information to come as we get closer to implementation.
Thanks, Amy.
Whoops. Okay. I wanted to provide just a little information about part of the implementation for the Long-Term Services and Supports Presumptive Eligibility Program. You've been hearing about this program for a long time, periodically here and there. We are slated for an early 2026 implementation date. And as part of the implementation, kind of a lot what happens internally here is we have to add to or revise our current rules and regulations. And so it's a really long process. They have to be drafted and then move through a really lengthy clearance process here internally. And then in the later stages where we are now, we start to be involved with presenting to the Medical Services Board. And so what I wanted to do ahead of time is to let this group know that coming up in the next couple of months, there will be an opportunity for all stakeholders, all interested parties to participate in a public rule review that is put on, or I guess hosted by the Medical Services Board. And so ahead of that, just kind of help shape your thoughts and help you kind of determine if that's something that you would like to attend and be a part of, I wanted to provide kind of a sneak preview of what our revised rule is going to look like. Again, because we are still awaiting federal approval for LTSS presumptive eligibility, we can't really delve into a ton of program details. However, here is a general idea for what's contained in our rule, our newly created and updated rule regarding LTSS presumptive eligibility. It goes into the definition, scope, and purpose of LTSS PE in that it allows the provision of some supports while someone's long-term care Medicaid application is being processed. One of the purposes of this new program is that it will reduce the time that those in crisis must wait before receiving care. We've also talked about the LTSS PE eligibility criteria. What we're looking at is meeting level of care or eligibility and financial eligibility for home and community-based services, attest to meeting disability criteria, and also meeting some defined crisis criteria. The rule also goes on to talk about the services and supports that we intend to provide during the PE period while someone's long-term care Medicaid eligibility is being determined. And that may include things like personal care, homemaker, respite, electronic monitoring. Electronic monitoring can include medication reminder and a personal emergency response system, transition setup, and home delivered meals. We also intend to include state plan benefits, including targeted case management transition coordination, as well as a pathway to receiving skilled home health. We also intend to provide application support for long-term care Medicaid, risk mitigation planning, and contingency planning provided by our transition coordination agencies. And then the roles and responsibilities that are unique to LTSS-PE are also defined in our rule. And that includes an enrollment coordinator, which will be a state staff person that will be hired in the next, hopefully, fingers crossed, hired within the next month or two. That will be someone who's responsible for receiving and screening the referral forms or applications for LTSS-PE, tracking someone's eligibility for long-term care Medicaid during the presumptive eligibility period, and doing some other tasks associated with the program. Also, transition coordination agencies will be really the facilitators of this program, in that they will be connecting those approved for PE to services and resources. I mentioned in the bullet above this, completing some risk mitigation planning and contingency planning, and providing other kind of means of support. And then the last bullet, counties and case management agencies, their roles and responsibilities will be largely, we anticipate, largely unchanged by the implementation of this program. It will be more a matter of those entities being aware of this program, in that they'll see kind of some, some system changes regarding LTSS PE and other kind of parallel happenings during the PE period. Um, So I mentioned that our public rule review is going to be happening soon. It's actually later this month on September 22nd. And if you are interested in attending that and taking part in that, I will be able to provide some additional details about how to join that and when it is, and how to log in or attend in person if you are interested. But beyond that, some additional kind of medical services board events will be happening throughout October and November, and moving towards what we hope will be a passing and implementation in a timely manner of the program. Any questions about this? All right. And then we have had a lot of conversation in these meetings as of late, as far as what you all would like to see and what you want to learn about and talk about during these meetings. A few months ago, when you took part in a survey during one of our council meetings, that was really helpful. Your responses, engaging your levels of interest, were really helpful in helping us decide what some future topics would be. That being said, while we do have kind of a nice outline that will hopefully take us through 2025, we are always, always, always open to additional ideas. If one of you attending today would like to present, just some wisdom to share with other council members, that would be great. Other ideas. We are always happy to hear those, as we want this to be a meaningful and useful use of your time. And of course, a collaborative space where everyone feels a part of the group and can present and share information as they'd like. That being said, here is just an idea for how we've mapped out the fall and winter of 2025. What I need to add to this future meeting agenda is something that was going to be part of today's agenda, which is Sammy here at HICPUF was going to provide a walkthrough of individual inReach. It's looking like that will happen later this fall, possibly in October. So in your imagination, add this to the upcoming topics list, is a walkthrough of individual inReach. Also, we intend to provide some information on the Money Follows the Person capacity grant program and what that closeout looks like. Information on adult protective services, a presentation on person-centeredness, program for all-inclusive care for the elderly, or PACE, long-term services and supports presumptive eligibility. Again, much more information to share about that, as well as an overview of waivers and home and community-based services. I'd like to pause here and see if anyone has any additional topics that they'd like to suggest that we cover. Or if you have thoughts about this list, if you like this list, if you think it is, if you think that these things are relevant for this group to discuss and learn about, if you think we're off base. Okay. Any questions about things in general, or is there anything that anyone in the group would like to discuss? Any walk-on items? Oh, thanks, Jesse. I really appreciate your comment in the chat. These topics have been great, and I've appreciated these meetings specifically. We really appreciate that. Thank you. Go ahead, Shannon. Thank you.
Yes, I was wondering if when you discuss the waivers more, kind of giving a little more in-depth discussion on the difference between someone choosing the community first choice waiver versus just an HCBS EBD waiver. That seems to be tripping a lot of people up, including myself.
It's a great suggestion. Yep, we can definitely go into that, and I really appreciate that. What else? What else would you like to see? What should we add? Anything you don't want to hear about? Okay, I'm not seeing any. Oh, sorry. Was someone talking?
Yeah, sorry. This is Tiffany Blue from Region 2A. We're the local contact agency here. And I was just wondering, and maybe you don't have this answer, but wondering what the kind of state of home care agency capacity is looking like now that individual inReach has started. It's been going on for about 2 months now. And as we move into some of these other initiatives that are slated to start at the end of this year, beginning of next year, just wondering if there is concern around like home care agency capacity and staffing for caregivers and homemakers especially, or if there's any initiatives around driving support and staffing in those areas too.
Yeah, thanks for asking about that, Tiffany. I don't know that I have any updated information about kind of how this is rolling out regarding provider agency capacity. I don't know if any of my colleagues who are attending this afternoon have any updated information, but I think that is definitely something we can take back and work to find some updated information for this group on.
Thank you.
Any other questions or comments on this or anything else? Okay, I'm not seeing any comments or hands raised, so I think that that brings us to the end of our time together. I really appreciated the agenda and those who shared information and questions and comments today. And as always, you can feel free to reach out to any of us, but specifically Matt Bohannon and Chanel Pugh are the administrators, or what are you all? The leaders of this group. I can't think of the word right now. Regardless, there is their contact information. So if anyone has any questions or suggestions in the future, you can feel free to reach out to them. All right. Well, thank you all again. We really appreciate you and your attendance to this group and your participation. And until we hear from you again, we hope that you have a nice September. Take care. I'll hang on for just a second in case anyone has any questions or comments for a smaller group. Jesse, I'm so sorry. Did I let everyone go and I didn't see your hand raised? My sincere apologies.
That's totally okay. And also, this is Jalen Oriano with Foothills Gateway. It just has her name listed at the moment, so I apologize.
No problem.
I wanted to mention just really quick, I feel like you guys have put a lot of intention into this transition stakeholder meeting recently, and I wanted to recognize that. I know that we aren't always the most chatty group because we're busy with a bunch of other things, but I'm really appreciative of all the information you're providing, and I feel like it's really helpful. So I wanted to make sure I give you some kudos there.
Jesse, that's really kind, and I know this team really appreciates it. Thank you so much. I
You're
appreciate
welcome.
that feedback.
Yeah, have a good day.
You too.
Thank you. Nice job, Amy.
Everyone,
Great job, Amy.
thanks.
Yeah, I think oh,
I'll
I
go
think it's
ahead and,
just us and a straggler.
yeah, and just us and Tom.
You can stop the recording.
Oh, yes, I sure can, huh? Can I though? Do I know how?
Oh.